So for those of you that don't know me, so my name is obviously Rachel, and I am, because I can't get off the board, I am the AIAC rep, which means I get to be the point person for the GLR for all things internship. And it's actually, it's a co-chair type position. So I have somebody else that is my partner in crime. But my role within the committee is all about supporting internship sites. So if there are challenges with interns or there are questions about forms, things like that, you come to me. If it's a site that is looking at becoming a national roster site, then they usually go to my partner in crime, and she is able to review everything. So we've been able to split it that way to try to get a little bit more support. So tonight is the first one we're doing this year, and we're doing a very different setup than we've ever done for these. So I don't know how it's going to go. We're just going to find out, and we're going to try it. And as always, we'll learn from it. So we have three panelists joining us tonight, and they're all incredible music therapists. And I was so excited when all of them said they wanted to do this, because I was like, oh, I'm with really cool people. So I'm just going to go in the order for which I found bios or were sent to me. So I'm going to tell you all about the incredible Allison Duran, who is a board certified licensed music therapist based in Cleveland, Ohio, working in the Metro Health system, both in inpatient and outpatient settings. She holds a Bachelor of Music from the University of Dayton and a Master's of Arts in Music Therapy from Cleveland State, where her graduate research focused on clinical supervision in the field. With a trauma-informed person-first approach, Allison values dignity, respect, and strength-based care. You're very good with language, Allison. Her clinical experience spans medical, behavioral health, educational, and residential settings. And she also, because she does way too much like all of us, she currently serves as the president of the Association of Ohio Music Therapists and as Ohio State liaison to the GLR. And nationally, she's an assembly delegate and board representative from she will be from 2024 to 2026, advocating for the profession through leadership and policy development. So that's Allison. And then we've got the amazing Tony with us tonight as well. And he has been working in developmental health since 2017. He earned his undergraduate degree from Indiana University, Purdue University, Fort Wayne in 2017, and his master's in music therapy from Augsburg in 2023. He's also certified in DIR floor type and approach, is it DIR or DIR? I probably said it wrong. I apologize.
It's DIR. It's an initial for
DIR.
some. Yeah.
Okay, well, I work in hospice. What can I say? Floor time, an approach used to promote individual development through respectful, joyful, play-based experiences. And then finally, we have one of the most exceptional therapists I've had the opportunity to be in the presence of, Miss Lisa Gallagher, PhD, MTBC, who got her Bachelor's of Music Therapy from Ohio University and her Master's in Arts and Counseling and Human Development from Walsh University and her PhD in Health Psychology from North Central University. She is the founder of the Music Therapy Program at Cleveland Clinic and is the Research Program Manager there for the Arts and Medicine Department, and has a secondary appointment with the Physical Medication or Medicine and Rehabilitation Program. She's a clinical music therapist, researcher, and author, and she's a frequent presenter at the local, national, and international level. And she is adjunct all over the place. She's written lots of things. She's kind of the most amazing, lots and lots of stuff. And we could probably talk for hours about all that Lisa has done. So these are our panelists tonight. I'm going to go ahead and I'm going to mute, and I'm going to pass it over to our panelists to kind of take the lead. You all should be able to share your screen. There's no reason why you can't. I don't know, Allison, if you want to take the lead with that. I will navigate the chat and kind of pop in periodically. But true confessions, I do have two children running around tonight, and my husband is also on a call tonight. So if you see my screen go off, just bear with me. Over to you guys.
Well, hello, everybody. I am Allison since we have a phone call person, just want to make sure that you know who is speaking. I am Allison Duran, like I said, or like Rachel said, I'm in Cleveland, Ohio. I think what's really unique about who you have here today is that all three of us work in kind of various areas, and over the careers that we've have had opportunities to step into various situations. And so I think before we kind of go right into questions and possible scenarios and kind of provide the rationales for what might be the correct answer during the test, it may be helpful for us to kind of give some takeaways of the different settings that we've been in or that we're currently in. So I can start that off. I've had the privilege of having the majority of my career in Cleveland, Ohio, starting in community-based work. And then now working in one location within a hospital system. When I was community-based, I did a lot of school-aged things, but then started transitioning into more mental health detox, active addiction, recovery from addiction, and then mental health. And so when it comes to safety, there's a lot of things to consider. And it's not just safety for the patient or for the client or however you refer to them. It's also safety for yourself. And sometimes that can get overlooked. As therapists, we tend to think wholly about our client, which is so important. That's so important thinking, but it's also really important to maintain your own safety. So one of the major takeaways that I have from working in behavioral health and medical settings comes from a more professional development and safety side, which is acknowledging self-care and professional boundaries. Knowing when to say no for your own self, and then also knowing when there's appropriate need to set a boundary with a client, with a patient, especially working in mental health, where sometimes the questions that are asked are too personal, and knowing when you disclose information and when you don't disclose information, meaning anything that's personal to you. It's what area of Cleveland do you live in? And I'm just going to use Cleveland because that's where I live. What area of Cleveland do you live in? It may seem like a very innocent question, but it could lead to an inappropriate interaction outside of the workspace. So you can be general, just knowing what those boundaries need to be, and that's remaining within scope, but also knowing the policies that are within the setting that you're in, the organization that you're with. One of the other big safety situations from working in medical and behavioral is, from the medical side, monitoring infection protocol, risk falls, and knowing what buttons to push and what buttons you don't push, what buttons are within your scope and what buttons are not. In behavioral health, it's also important to acknowledge buttons, like safety buttons and things like that. But it's also important to know what equipment may be appropriate and not appropriate, depending on where you're going and what you're going into. So those are kind of some major takeaways that I have from working in the behavioral health and the medical settings. I would say that a lot of that also pertains to schools. When I was working in schools, a lot of the kids that I was working with were in the special ed room, but they were not in there for intellectual purposes or developmental purposes. They were in there due to trauma and not having necessarily stable living conditions. And so I was dealing with severe behaviors, but that were not necessarily intellectual behavior. It was definitely more of the I'm angry at the world behaviors. And so acknowledging, again, what equipment do I take in? It may be appropriate for a school, but is it appropriate for the people I'm working with? And so it's just finding that balance. I'm going to stop talking and let Tony and Lisa kind of provide what maybe their major takeaways are from their settings.
Yeah, I'm Tony. I work primarily in developmental health. So that means individuals with intellectual developmental disabilities. My kind of niche of practice is autistic children. I do a little bit of hospice work and then a little bit of individual music psychotherapy, primarily self-referral, so people who are coming because they want to, not because they have to, which is a nice thing and a different thing than a behavioral setting. For my settings, it's really important to know the systems that you're working within because I work with a lot of people who can't reliably communicate. And when they can communicate, they can't always do it robustly. So they might not have full use of language. They might only have gesture. They might only have a limited vocabulary of like 30 words or less. So, in thinking about their safety, it's really important to know um, the structures that I operate within. If I see something that is questionable or seems like that person might be unsafe, who do I need to tell? What systems get kicked into place by my report of what I've seen? And I also need to know who is in that person's life pretty well. So a lot of times with the older adults with intellectual developmental disabilities, they no longer have family as their primary guardian. They might be under staff, they might be under a paid guardian. So I need to know who is on that person's team and who is primarily responsible for them and in helping them stay safe. I did a lot of years as an in-home therapist. I'm now primarily clinic-based, but in-home work also has its own set of challenges and safety concerns, primarily because I'm going into someone else's space where I'm no longer in control of where the exits are, and I'm no longer in control of knowing where everything is in case I need it. So that comes with needing to know where the safety items are in the house. Where's the fire extinguisher? Where are the exits? What's the safety plan in case something happens? Who else is home with us? Who's in the home? What animals are in the home? What dangers are in the home? All those things are important for me to know as an in-home therapist. And then I supervise a lot of new professionals that come to work for the practice that I work for. And it's a lot of setting up those boundary pieces, like Allison was talking about, of what are my boundaries? What are my limits? Where do I feel safe? Where don't I feel safe? What work can I do safely? And then the last piece I'll tag on is that I'm part of the queer community and I live in a relatively small city. So I have to balance a lot of dual relationships, a lot of small community spaces in which the people I support might also be the people I see on the dance floor at 1 a.m. And what does that mean as a therapist? So that's another piece around safety and boundaries to consider too.
So I'm Lisa, and I'm the senior member of the panel tonight. And I have probably worked with every population out there. I started my career, and I hate this title, and I'm glad it has changed since then. But I started my career as a QMRP, which was then called a qualified mental retardation professional. I worked in a 50-bed facility for adults with intellectual and physical disabilities. And my job was to be like a case manager for 14 of the individuals. Um, with that, there were a lot of safety issues that I had to really watch out for. I was on call a lot, and I worked one evening a week. And I swear the one summer that I worked, we had tornado warnings like every Monday night that I worked. And so I I had to get 50 residents into one hallway. And we locked them down into one hallway, and it was not a fun thing. So I had to be really aware of what all the procedures were. So I think that's something I really took away, though, of knowing what the emergency procedures are everywhere you work. When I was a contractor for different agencies, I would say, oh, I'm a contractor here. I don't need to know that. But yeah, well, yeah, you kind of do, because if there's a fire in the building, you kind of need to know what you're supposed to do, where you're supposed to go, how you can help the clients and the staff. Um, so after I left that job, I went to a community setting where they contracted me out to everywhere. Um, I did senior centers, I did inpatient mental health. I did outpatient mental health. I did inpatient substance use disorder. I did outpatient substance use disorder. I did dual diagnosis. I did forensic psych, which I absolutely hated. I did not feel safe there. Let me just say that. I did not feel safe there. And that's the year I was pregnant. I think that added to it too. Yes, Rachel. Um, so, safety was very much something I was really aware of that year. Um, and then I started contracting at the hospital at Cleveland Clinic, where I started the music therapy program, and then ended up going there full time. I spent the first half of my career there in palliative care, and then the second half doing management and then research. And now I'm dabbling in music therapy again, as well as research. So I do outpatient neuro and chronic pain. So I think in the hospital setting, what I've seen from a safety perspective is infection prevention protocols have really amped up. Obviously since COVID. But foaming in, foaming out of each room every time you go in and out, um, disinfecting the instruments. We used to never care about that. You used to go in and out and not clean an instrument. Yeah, right, Tony. But now you have to clean everything. And there actually were a lot of instruments that after COVID, when we came back into the hospital setting, we had to get rid of because our infection prevention folks said, these are too porous. You can't clean them all the time, so you can't use them anymore. So being aware of what instruments you can and cannot use. And then knowing, with contact precautions in a hospital setting, who can you go in with? Who should you not go in with? What can you take in? What can you not take in? And just having that awareness of your surroundings and, and it's also, not just physical safety, but emotional safety and verbal safety as well. And I think something I'll be getting into with my questions, and I'm not sure about the other folks, but the safety and potential harm of music experiences as well. Because we all think, well, music is great. Well, it is, but it can also cause harm. So we need to be aware of that and the contraindications of music. So I think that's where I'll stop.
I think one more point that kind of all three of us touched on that I would also just like to add, if that's okay, is within safety and professional development, the opportunities for collaboration in our field are extremely high. We collaborate with individuals all the time. And within that collaboration is always the opportunity for not only advocacy, but education. And so what Lisa is saying from the contraindications of how music can be utilized is something that I've run into in the hospital where somebody is being extubated and wanted music therapy, wanted me present playing guitar so that we didn't have to listen to all the other sounds that were happening. We could have music present instead. And the neurologist said, oh, we can just play, like bring a CD player and play his favorite song. And I was like, so I understand why you would think that would be helpful. Let me explain some of the research behind this, and then provided evidence-based information about the difference between recorded music and the risk that comes with that, and how live music can support, and here's why, and the research that backs it up. And the neurologist said, I didn't know that. Thank you for telling me. I'll page you when it's time. And that's an opportunity. So that's a real life opportunity, a real life example of that collaboration, that opportunity for advocacy, that opportunity for education within my scope of practice for the setting that I was in. And with Tony, what he was talking about with knowing not only who's in the house, but also what dangers lie in the house is also important for if you have to report something like for children protective services, or adult protective services, when you music therapists in the state of Ohio are mandated reporters. And so when you report that information, that's information that you also need to provide. Or what are those dangers, and what was in the house, and all these things. What did you observe? And it's knowing who you connect with to report those situations. So the collaboration is extremely important, but it's also knowing who you go to. Yeah. So the collaboration side is also extremely important for not only professional development, but for safety, because the safety of you of reporting that is very important, because that's your license. And in Ohio, anyway, if you're a music therapist, you have to be licensed. We gained licensure last year. So, or gained it 2 years ago, but all went through the process last year, becoming licensed professional music therapists. So that's part of our license now. But anyway, so that's I just thought I'd touch on the collaboration because we all three kind of circled it but didn't pinpoint it. So there was that opportunity. I just want to give our fellow interns that are here tonight an opportunity. Do you have any questions or any comments before we get into the next part, or thoughts that maybe you'd like to share?
Lisa, I'd like to know how to reach out to you, because my final project is to do a proposal for music therapy in a inpatient setting.
Sure. I'll throw my email in the chat.
Thank you. I appreciate it.
Yeah, you're welcome.
As someone who's also a member of the queer community, if there's time, Tony, if you could go a bit more in depth into how you approach those situations where you might see folks that you interact with out in the wild, that would be lovely. If there's not time, then that's totally fine as well.
Yeah, I don't know what the vibe is for tonight. Do we want to take time now? Do we want to wrap that around at the end?
I think if you're comfortable answering it right now, Tony, I think we answer it right now.
Cool. Yeah, totally. So a lot of this is wrapped up in my informed consent procedures when someone is starting therapy with me. I talk about generally what it will look like if I see you in public, which is, hey, I'm not going to acknowledge you. You are welcome to come up and talk to me if you would like, to wave hi. I will keep it, short. It will be brief. Fun to see you. All right, I'm going to go. If I am with people, I will not introduce you, and I will not tell them who you are after they leave. Typically, my phrase is, there's someone I knew a long time ago. I'm surprised they remember me. And that kills a lot of conversation. And then my friends know what I do for work. So if they push it and I keep going, they can bridge that gap a little bit and know to stop pushing it. When it comes to queer clients specifically, we have one gay bar here in the town that I live in. So I just warned them ahead of time, hey, you might see me out and about at the bar, at pride events. I may look different. I may dress different. I may act different. I may be drinking alcohol. I may be with other people. If you feel any type of way about it, we'll talk about that the next week when you come back to therapy. And then they get to make the decision of, yeah, that's something I can handle, or nope, that's too weird for me. I need to stop. So that's typically what it looks like. I prepare them ahead of time. I give them informed consent on what it looks like. And then I give them the chance to process the experience afterwards the next week in therapy.
Joseph, I know that you are on the phone, so I just want to give it just a little bit more time in case there was anything that you're thinking. Okay. Anna, just to add to what Tony said, recently in the hospital, I had a patient that I worked with that was around my age, and we had really great rapport. It was a younger patient who was recovering from a stroke and was really struggling processing that it happened to that person so young. And when the patient was transitioning out of the hospital, they said to me, "Oh yeah, come on down. I'll show you around the area that I live in." And that opened the opportunity for me to say, ethically, I cannot, blah, and it's following my scope of practice, but also following what's written in my license for the state of Ohio. And I was like, if I go there and I see you, I can't approach you. You could approach me, but I will not introduce, like some of the same stuff that Tony said. It's just because I work within the hospital system, I don't necessarily have that informed consent type of situation that he was referring to. But it's just a nice spiel to have kind of in your back pocket, and practice saying it, but that you can also revise it based on what area you're in or what setting you're in, because every state, that now that we have so many states of licensure, which is wonderful, may have different requirements. So just to piggyback off of what Tony said. All right.
Hey,
Great.
sorry. I was trying to unmute myself, but I pressed the wrong thing. It's supposed to be *6 and I pressed #6. Anyway, I also had a similar question that was asked to Tony that it was answered obviously. I'm also in the same, like I'm also in the LGBTQI community as well. And I started recently during my internship a community group for this pride center that's near me. And I also had a similar like fear kind of thing about that as well, because I just don't want to cross any boundaries and just want to make sure everything is like clear in that, and like they know kind of that there's professionalism there, but also like I'm friendly enough. Like of course I'm, so yeah, so that was a similar question I had as well. So yeah.
Yeah, the last thing I'll throw out there is just to make sure you have like a mentor or a supervisor or someone who's been doing it a while and can help guide you through
hmm
things get real sticky, because things are going to get sticky working in a small community. So
Thank you.
Perfect. Thank you for the questions, everyone. Rachel, are we okay to go into questions now, or that's cool? Okay, awesome. So speaking of collaboration, Tony, Lisa, and I collaborated and put together a Google slide that has alternating questions of safety and professional development, very similar to what you may see when you take the CBMT exam. So when we go through these questions, and Joseph, since you are on the phone, we will read them for you so that you can see it and hear it. I'm sorry, so you can hear it since you can't see it. That's what I'm trying to say. And there will be, just like the CBMT exam, there may be 2 or 3 answers that sound like they're correct, but there is one that is the best choice. So that's just important to consider when we're going through the questions. So we'll just start right off the bat. I'm going to share my screen.
Can I
Just
ask
kidding.
before you even get there, because I'm sure it'll come up, will
Sure.
these questions, responses, or whatever be available to us following this
Yeah, we can definitely send them out.
session? Okay.
Sure. As long as that's okay, Allison, Tony, and Lisa. That works for you guys.
I mean, I'm fine with that. Yeah. I mean, they're all, just know that Tony, Lisa, and I wrote all of these questions. These are not actual real questions from any exam. These are just from our experiences and the rationale that supports it. So just so that disclaimer is out there. But yeah, that's fine. All right.
But I'll give a disclaimer. I don't know about Allison and Tony. Mine are written in the style of the CBMT exam. I have served on the exam committee, and I just finished working on the new self-assessment exam. So, yeah.
Oh, of course you did, Lisa.
Of course I did. I know.
Of course you did.
Another person who can't stop working, right? Yeah.
Yeah, I was gonna say I did my best to imitate the style, but I'm not connected with CBMT at all and have not looked at the test since I took it in 2017. So take them for what you will.
Yes, and full disclaimer, also have not served at that capacity as Lisa just spoke. But I will tell you that just to give my undergrad school a little bit of a woohoo, I will tell you that my undergrad studies were all built like the CBMT exam. So I tried really hard to think about how my stuff was done at the University of Dayton when I was phrasing stuff, because I know that at the time, Dr. Susan Gardstrom and Dr. James Hiller had served at that capacity. So a lot of our education was presented the way that the CBMT exam was. Yeah. So yeah, I know, Anna. It's bananas. That's how they did it. That is that's
That
how
makes
they
so much
prepared us.
sense now.
Yes, doesn't it? Now you're like, now I understand why I went through that. Okay. Yeah. That's so anyway, yes. Anyway, so here comes the first question. Question 1, it's from the domain of safety. During a session in the ICU, a patient becomes non-responsive. What should the music therapist do first? A, continue the session calmly. B, call for medical assistance immediately. C, document the event after the session. D, ask a nurse to check on the patient later. Rachel, is it a question, like do people respond, or we just give time for people to respond? It's typically the case.
So
Should have asked this.
it's all good. So in the past, what we've done is we've had people put answers in the chat. And then we can see if people get it right. And if they get it right, explain. If not, somebody else explains. It's been pretty chill. So
All right. So I guess throw for those that are using chat today. Okay. Thank you, Anna. Yeah, so I'll give like a countdown of 5, 4, 3, 2, and 1. So it would be call for medical assistance immediately. The rationale behind that is that immediate medical attention is the priority in any emergency situation. So within the hospital that I work in, there is a button that I can push. It's the blue button because it would be a code blue at that time for me. So just knowing what buttons to push. I'm also very lucky that the hospital that I work in is brand new. Metro just built a brand new hospital. So there is a electronic board in the room that tells me who the nurse is, who's the call, like who the doctor is, who's first call, all those things. So it also makes it easy for me to call out for anyone that I may need. All right, any questions? I'm also fine if you just interrupt me with a question. But, okay. So our second question comes from professional development. The question is, a music therapist wants to ensure ethical practice in a hospital setting. What is the best action? A, use the same session plan for all patients. B, skip documentation to save time. C, pursue continuing education in medical music therapy. Or D, ask nurses to lead music sessions. Yeah, this one is a 5, 4, 3, 2, and 1. It is continuing education. The rationale for continuing education ensures competence and ethical practice in specialized settings. So in the medical side of things, there are certain situations that may look different. Even when I transitioned from inpatient psych into purely medical, there were things that I needed to learn and information that I needed to gain. And so the best way for me to do that was through CMTs. Question 3, safety. What is a key safety measure when providing music therapy in an isolation room? A, avoid eye contact. B, wear appropriate PPE and sanitize instruments. C, use only vocal interventions. D, bring multiple instruments. Yes, 5, 4, 3, 2, 1. Wear PPE and sanitize instruments. The rationale, of course, following isolation protocols, PPE sanitation is crucial to prevent cross-contamination and protect patient and therapist. So what what Lisa had said a little earlier about knowing what you can and cannot take in, there's different types of isolation within the hospital setting. So you have airborne, you have contact precautions. And so knowing what limitations you have in going into like an airborne room, what you have to wear from a PPE perspective, and then what instrumentation would work or not work. For example, airborne, you're more than likely going to be wearing an N95 mask. It's not going to be helpful to do an intervention with a kazoo. You have a mask on. So it's just knowing what you can bring in and sanitizing.
And Allison, could you please define what PPE is? Just because we can't always assume everybody knows.
Sure. Thank you. Personal protective equipment. A lot of us got confident or got comfortable using PPE, the term PPE during COVID. Some of those procedures are still intact, depending on where you are. At the time that COVID was very high, I was in inpatient psych. And so trying to explain protective personal equipment in inpatient psych was a challenge in itself. So that was, everything was isolation then because we didn't know. So it was just, what do we do? What do we sanitize with? Yes.
And also, Brian put in the chat that also in skilled nursing and assisted living, there's a lot of contact precautions that are significantly more consistent, I would say, than some of the airborne.
Yeah, so just to throw that out there, since Brian brought it up, Brian, what are some of those contact precautions that you may see more frequently in skilled nursing and assisted living?
Oh, well, we definitely have the aerosol, droplet.
What might some of the diagnoses be related to those precautions?
Well, the big one's COVID.
Yeah.
Or pneumonia. We have my full-time job, I work as an activities director in a skilled nursing facility, so I should have these off the top of my head. I apologize.
It's okay.
But there's some kind of skin disease that's easily transferable by contact.
Probably scabies.
No, it's got a really weird name. Like, it's like 3 miles long. Starts with a K. But yeah.
Yeah, a big one you're probably
read the sign outside the door and follow what it says.
Yeah, a big one in skilled nursing and also in the hospital is going to be C. diff, which is highly transmittable. That is related to intestines. I saw. So that's a big one. And typically with C. diff and with COVID, you're going to use bleach wipes. So also knowing what equipment maybe should not get bleach wipes because you'll ruin it. Neurovirus. Yep. Lisa, I saw that you unmuted yourself. Was there a...
Yeah, when I had shingles. and I was
Mm.
hospitalized for shingles. I was in one of the air pressurized rooms and on contact precautions, and yeah, so
Yeah. All right, let's move on to that next question. Question 4, a music therapist attends an interdisciplinary team meeting in a hospital. This demonstrates A, peer supervision, B, clinical independence, C, professional collaboration, or D, continuing education. 5, 4, 3, 2, 1. It is professional collaboration. Rationale, team meetings are a core part of interdisciplinary collaboration, aligning services to ensure optimal patient care. This can be really great if you're working in inpatient psych. Often when you are leading groups, they ask how the patients did. So that's an area that might get used. Question 5, a music therapist enters a hospital room without using hand sanitizer. What guideline is being violated? A, HIPAA compliance, B, infection control protocol, C, ethical confidentiality, or D, evidence-based practice. 5, 4, 3, 2, 1. It is infection control. Hospital protocols require hand hygiene to prevent the spread of infection. Skipping these steps violates standard safety procedures. So Lisa and I both work in the Cleveland area, but we work for different hospital settings. So you heard Lisa say you have to foam in and foam out. The clinic has different hand sanitizer than what my hospital Metro uses. So they refer to it as foaming in and foaming out. For me, it's just Sani in and Sani out, sanitizers in. So it's also knowing the language that's used in your organization. Our next question, hospital administration wants to use a music therapist in patient transport roles. The therapist should A, agree to help as part of the team, B, refer to the AMTA scope of practice, C, file a complaint, D, decline based on union rules. 5, 4, 3, 2, and 1. When in doubt, go back to your scope of practice. Yes, that is the rationale. It defines our appropriate responsibilities. Non-clinical transport duties fall outside of a therapist professional role. So it's just important to know that information and also to use it to back up why you may be saying no. Going to question 7, which of the following is the best way to ensure infection control when providing music therapy services in a hospital setting? A, use hand sanitizer only when visibly soiled. B, wipe instruments once a day. C, clean instruments before and after each session with approved disinfectants. Or D, wear gloves at all times during sessions. 5, 4, 3, 2, 1. Yes, clean instruments before and after each session with approved disinfectants. Infection control requires routine cleaning of materials between uses, particularly in healthcare settings. Gloves are not always required, but hygiene and disinfection procedures are. So it's just important to know. And again, since Lisa and I live in the same area, we probably have similar products that are being used. A gray top glove or gray top wipes versus the orange bleach wipes versus the purple top wipes. And so knowing what wipes I have to use based on what room I just came out of, and also in what order I have to put the gloves on, what order do I don everything off or don everything on? And then what order do I doff everything? Meaning remove all of the equipment. And knowing then what in order do I put everything back on so I can disinfect everything I use. It's a joy. Question 8, you were asked to supervise a music therapy intern, but you have no supervision experience. What is the most responsible course of action? A, accept the role and learn as you go. B, decline and explain you lack training. C, accept but only supervise in areas you are competent. Or D, refer the intern to an experienced supervisor and seek supervision training yourself. 5, 4, 3, 2, and 1. Yes, ethical practice involves recognizing your limits. Interns deserve qualified supervision, and the therapist should pursue further professional development is D. There are guidelines to supervision with interns as well through AMTA. So if that is also down the line, you would like to supervise an intern, know what not only knowing your limits, but also knowing what is expected is also really important. Question 9, you're asked to lead a drum circle in an inpatient psychiatric unit. What is a key safety consideration? A, select songs with religious themes for comfort. B, provide unrestricted access to all instruments. C, choose instruments without detachable or sharp components. Or D, only allow clients to choose their own instruments. 5, 4, 3, 2, 1. It is C. Clients in psychiatric settings may be at risk of self-harm. Instrument selection should consider physical safety, avoiding objects that can be used harmfully. I know that in the rationale, it specifically states self-harm, but it's also just important to, as one of the one of the things that could happen within a session is music can be triggering. Thank you, Lisa.
Contraindications.
Thank you. Oh my gosh. Contraindications. And so being aware, we never know what's going to happen. And so just reducing that risk is needed. Thank you, Lisa. Finally,
I was
go
just
ahead,
going to
Brian.
say, I think there are things that come to mind before even beginning to choose the instruments in that situation, but it's not one of the choices on there. It's like, I would want to know if any of these patients have PTSD or would be sensitized to percussive sounds, and it wouldn't be a good thing for a group session. So, yeah.
Yeah. And so throwing that question out there, how may you find out if those patients have those diagnoses?
I would start by reading their profiles and their charts.
Yeah.
Yeah.
Yeah. So an EMR or the electric medical record can be really helpful in when you're chart reviewing. I will tell you that psych can be really tricky when it comes to that, especially if a patient was brought in by the police department and they're under a 72-hour hold, or as you may hear, they were pink slipped into the system. They may not have an electric medical record associated with the facility that they're at. And so they may not have everything. So that's where I really push for trauma-informed care. You come in with a trauma-informed perspective about those types of things. So being aware that drumming may not be the best intervention to have on a specific unit, but then offering, again, that education and advocacy of maybe what's a more appropriate intervention. I found in inpatient psych one of the most positive interventions that I had, which reduced that situation of the drumming, but also helped with group cohesion. And if they threw it, it was fine, were boom whackers. Simply because if somebody throws a boom whacker at me, it's plastic, or hits another person with it, yeah, there's the potential of that harm, but it's plastic. It's not necessarily going to be as harmful as like a rain stick or a triangle, even, because that's metal. So it was just knowing what are the options that I have and also what equipment was available to me. Yeah. But Brian, those are really great. Those are very valid points. Absolutely. All right. Final question that I have for my round of things is, as part of your professional responsibilities, which activity best reflects advocacy for the music therapy profession? A, posting client testimonials on social media. B, submitting anonymous feedback to your employer. C, presenting a workshop at a local medical conference on music therapy and palliative care. Or D, asking clients to write letters in support of your work. 5, 4, 3, 2, and 1. Yes, advocacy involves educating others about the profession when it's appropriate, and that can be in professional forums such as conferences or public education. All right. I'm happy to continue moving forward when the next question pops up. Just let me know when you would like the answers to be shown.
Okay, sounds good. Thank you. All right, so a safety question. A music therapist is engaging a group of adults with neurologic disorders in a music listening experience. Some of them become frustrated and agitated. What might be the cause? A, they do not like the music therapist is playing. B, they are becoming overstimulated and confused. C, they are becoming tired after a long day of treatment. Or D, they cannot hear the lyrics clearly. All right. And go ahead, Allison. Yes, you both got it correct. The answer is B. They are becoming overstimulated and confused. And I apologize, I did not write the rationale here. But yes, that is one of the contraindications for individuals with neurologic disorders, is that a lot of times music that is loud or different types of music can cause them to become overstimulated. So you need to be aware of the music that you are playing. Next
Or the
question.
length of interaction that you have.
Absolutely.
Yeah. I limit my sessions in the neuro unit.
Yeah. So some of these other things are correct. I mean, they might be tired after a long day of treatment, but it really is more that they're being overstimulated. All right, a professional development question. Thanks, Tony. What is one way to ensure professional development while also engaging in best practice? A, rereading college textbooks. B, integrating current research into practice. C, asking other music therapists for advice on social media. D, repeating the same session plans for multiple clients. All right, and show the answer, please. Yes, you got it all. B, integrating current research into practice. That is definitely a way of showing professional development. Yes, rereading college textbooks could be a way of relearning things, but not the most exciting way. And it would not keep you up on the current research, what's currently happening. And Brian, you say B with supervision. Absolutely. Supervision would be great too, to add that in as well. And it's always okay to ask other music therapists for advice, but evidence-based practice and research is a little more appropriate and professional. And I don't always suggest asking them for advice on social media. Exactly. Exactly. All right.
Really quickly, I'm going to
Yes.
jump in because it is 8:29. And so technically our hour is basically up, but I do recognize that we are in a great flow state. But I want to be mindful of everybody's time. Because we did say we would go for 1 hour till about 8:30. I will look to our panelists. Are you guys okay going over a little bit since we're sort of in a place, or do you need to hop off? We're okay? So if it's so, we're good. So if it's okay with everybody, because this is just way too much fun. I nerd out over this way too hard. What if we went maybe about 10 more minutes worth of questions? If that works for everybody. And this is being recorded for anybody that is interested. And what I'm going to do right now before I forget is I'm going to go ahead and I'm going to put the evaluation in the chat so that it is there. No, I'll wait till the end because I want that to be the last thing so it doesn't get mumbled in all the answers. So forget I said anything. Let's do 10 more minutes.
All right, safety. A music therapist is working with a group of clients in a substance use disorder clinic who also have a dual mental health diagnosis. During the session, one client begins to actively hallucinate. Which intervention would be contraindicated? A, guided imagery. B, progressive muscle relaxation. C, singing. D, instrument playing. Exactly, A, 100%. If they're actively hallucinating, they're already imagining on their own. You don't need to add to it. So please don't do that. All right, professional development. A first-year music therapist gets a new position at an organization where they're the only music therapist. What is the best thing they could do for their professional growth? A, seek supervision or mentoring from another music therapist. B, ask their supervisor at work how to be a better music therapist. C, ask other music therapists for advice on social media. Or D, read what the literature says on being a first-year music therapist. Yes, you are correct. It is A, seek supervision or mentoring from another music therapist, because their supervisor at work is obviously not a music therapist. All right, next, safety. During a group music therapy session, the patient becomes angry and starts throwing things around the room. What is the first thing the music therapist should do? A, tell the patient to stop throwing things. B, call for other staff to come help. C, remove the patient from the room. D, make sure the other patients are safe. Man, you guys are good. Yes, D, make sure the other patients are safe. Excellent. Professional development. In order to continue to grow as a professional, it is important to routinely conduct a self-assessment. Once this is completed, the music therapist should A, forget about the items on it until it's time for the next one. B, choose one thing to work on and work on it for the next year. C, prioritize areas to address and come up with a plan of action. Or D, ask their boss what they should be working on and why. Again, you both got it right. Yes, prioritize and come up with a plan of action. Safety. A music therapist is working in a prison and notices there are still art therapy supplies in the room from the previous session. What is the best thing for the music therapist to do? A, put the supplies at the back of the room for the art therapist to get later. B, keep the supplies out on the table to potentially use in music therapy. C, call the art therapist right away and tell them to come back and get everything. Or D, lock the supplies away until the end of the session, then notify the art therapist. Yes, lock the supplies away until the end of the session, then notify the art therapist. Because who knows what the art therapy supplies are? Even pencils are things that are not allowed to be left out, and they have to be counted in a prison. If a pencil goes in, they have to be counted and they have to go back out. So the fact that the art therapist left things in the room is a big no-no. All right, next question. What is an important part of professional development as well as recertification? A, retaking the board certification exam. B, participating in continue education. C, giving presentations on music therapy. Or D, becoming a licensed music therapist. And yes, Brian, doing anything in a psych ward is very helpful. Yes, B, participating in continuing education definitely is very helpful for professional development and a requirement for recertification. Safety. A music therapist is working with a patient and begins to sing an upbeat song by the patient's favorite artist. The patient becomes angry and tells the patient to get out, or tells the therapist to get out. What might have happened? A, the therapist did not sing or play the song correctly. B, the patient liked the artist but did not like the song. C, the song triggered a memory of a traumatic event. And D, the patient had to go to the bathroom. You are correct. The song triggered a memory of a traumatic event. And this is a true story. This really happened to me. So, and it worked out fine. I did not get out because I stayed in process with the patient, and it ended up working out well. I did not leave her in distress, and it ended up being an excellent session. All right, my final question of the night. Integrating the music therapist's expertise, the client's preferences and needs, and the best available research is an example of A, evidence-based music therapy practice, B, biopsychosocial music therapy practice, C, psychodynamic music therapy practice, or D, humanistic. Yes, A, evidence-based. Excellent. Thank you. All right, Tony.
Great. I'll try to burn through these. All right. Music therapist is working with a child with profound intellectual disability who repeatedly pulls their hand away from the kabasa when the MT assists them in playing it. What's the best course of action? Pause the music until the client extends their hand. B, verbally encourage them to continue playing and provide praise when they do. C, stop using the kabasa and find an instrument they don't pull away from. Or D, slowly increase the duration of the kabasa playing over time to desensitize the client. Yes, it is C. We want to respect that person's autonomy, and we are not working on sensory desensitization anymore. That is an outdated concept of practice. Great. Next question. Music therapist is working with a non-speaking client who communicates through pointing and nodding. During their weekly visit, the MT notices a new pattern of bruises in a row on a client's arms. What should they do next? They should ask the client if someone hurt them. B, ask the caregiver about the bruises and document the bruising discussion and follow-up plans in their note. C, call Adult Protective Services. Or D, inspect the rest of the client's body for more bruising. Got some split answers here. For the sake of time, let's show the answer, which is B, right. So this will also depend upon the setting that you're in. In my setting, this would require an incident report to the state because bruising in a pattern requires an incident report, but that would go to the state. That would not go through APS quite yet, but think of populations that might bruise easily, like older adults, right? You wouldn't call Adult Protective Services first. You would check in with the point of contact first. Okay.
And Tony,
Yes.
Tony, I know that we have limited time, but I also think it's really important. This is where within a hospital setting, you would need to collaborate with other professionals. And if they've noticed the same thing, because that could lead to a conversation of calling APS. And then also how it's documented is important. So how documentation reads and who has access to that documentation is important to consider here as well. This would be, if this was documented, this would be a note that I would hide because I don't know who can read it and then who could be, so I can hide notes in someone's electromedical record. There's only certain reasons I can, and that would be a reason why. So if the abuser has access to the notes, they can't remove it or anything else.
My hesitation towards choosing that answer was, what if the caregiver's the one doing the abuse?
It's a potential there.
And as a mandated reporter, I wouldn't be reporting it to a caregiver, but I would be reporting it to a supervisor. I wouldn't, but call Adult Protective Services was the only answer that didn't involve someone who possibly could be potentially the abuser, who would want to cover up whatever,
Right.
you know.
I think this
I
gets
guess
to
because
the
you
point.
go ahead.
Yeah, I think this gets to the point of what's the test versus what you would do in practice, right? On the test, you need to read the question and take the question at face value. So yes, in practice, I would also be thinking about what is the caregiver, and I would default to my system's processes, which are tell my direct supervisor, file an incident report with the state. But the test can't go into that level of detail. So the test says, what should you do next? The next step is to address it with the caregiver. You might later call Adult Protective Services, but what is the next step?
Well, it does say put follow-up plans in their notes, so at least you have that line of documentation to follow through with.
Right. So maybe in your follow-up plan, you include, we'll call APS.
And I also think I want to just really quickly add that the first thing you're going to do is you're going to ask the caregiver, right? And say, you know, do you know what happened here? And they may say, no, we don't. And that's okay. And then you document that. And then you take it to the rest of the team that you're working with. From there, you make a plan. But it's always the person who's working with them, you know, like be it in a nursing home or be it a paid caregiver. You're always going to go to them first, like, hey, I noticed this. Have you seen this before? Because maybe they haven't. Maybe it's something new, right? That just whatever it might be. But that's always the first step. And Anna, you unmuted.
Yeah, I was going to say what ultimately pushed me toward the answer B was that regardless of whether or not the caregiver like would lie about the cause of it, even if they were like the cause of that injury, even just having that testimony and documenting it would be great for like paper trail for if anything did escalate. Was my perspective of it as well.
Rachel, I think you said the same thing that Tony said, but it just resonated better with me. What the rationale there makes a whole lot of sense to go there first because they're the person working with the most often. Yeah.
How about we do one more question tonight since we are totally over, but it's so great.
Sure. Yeah. Last question.
Tony, is there a certain question you want to do? Like, should I go to a different question or?
Let me look real quick.
I just want to make sure we honor because you also wrote great questions.
Yeah, and we're sending these out, so they'll get to see them.
Yeah.
Um,
But while Tony's thinking about that, I think Tony said something that was really important here was think about the test. The test can't give us all the elaboration that we're kind of providing in our rationale, but think about what like the test would say. What is next? To be very clear in what is the question that's being asked of you, and then what is the best answer based on the options that are there. Yeah.
let's go to the last question. Let's go to question 30 because I think it touches on some of these things. So a music therapist is working with a new client who discloses they are non-binary during the third session. The therapist feels uncomfortable supporting this client and separating their personal beliefs from the therapy. What is the best course of action? A, seek supervision with a professional with expertise in LGBTQ issues. B, refer the client to a different therapist. C, read articles about LGBTQ people in music therapy. Or D, focus the therapy only on topics unrelated to the client's gender identity. Again, a split question. I tried to make them a little tricky because I feel like the test is a little tricky sometimes. The best answer for this one is A. Music therapists, through our competencies and through our board certification domains, by being in MTBC, you are to be competent to work with people from a variety of backgrounds. So you are saying you are incompetent in our competencies if you refer on for that specific reason. So the best answer is to seek supervision with a professional with expertise in LGBTQ plus issues. You're going to find people in that community, no matter what population, no matter what age range you work with. So you need to be competent working with them.
Tony, I think another part that not only supports the rationale that you just provided, but also in if you read limitations to service, which has been a big conversation within the music therapy field, if you are in a small town like Tony is, there may not be another music therapist that you can refer the patient to, right? And that is a limitation to how many providers we have and areas people live in. And so referring the client to a different therapist may not be an option. And so supervision there really is another part of that rationale for that reason.
I think I'm clearly showing bias here because as a person who also identifies in the LGBTQ plus community, I would want to work with a therapist that wants to work with me.
Right. And who's making that decision in that scenario?
The client is making that decision.
Right. And
Okay.
that's what matters, that the client has the autonomy.
Yeah. But that same question asked with a different set of circumstances. So thank you for helping me to think about the test a little bit more and what's the test really trying to get at.
Yeah, I'm gonna just, oh, go ahead, Rachel. I'm sorry.
No, I was just going to say a major, major thank you to Allison and Tony and Lisa for being our panelists tonight. And I have put the link for the evaluation into the chat. Please go ahead and do that. Thank you all for staying on extra today. I will see what I could do about sending out the questions to all of you.
Oh,
Oh, you just put it in there? Even better!
yeah,
Allison, you're the hero.
I just for our panelists, I just changed the permissions so nobody can revise it anymore. But Tony and Lisa, I can revise it again just to give you all permission since you guys did add to it. But right now it is there's permission for people to view it, so they can view that PowerPoint.
Wonderful. And we will be having another test prep happening next month. I don't remember what our topic is, but we'll be doing one in August. We will be doing one October, maybe in November as well. I don't remember. Anyway, stay tuned. We'll have more of these. And they are all, as I said, they're all getting recorded. They're going to be archived on the GLR website. So if any of your fellow classmates are interested in some of these and they're going to be helpful, they should all be there for your review. So thank you all so much for hanging out on a Thursday night.